I'm gonna record. Okay, cool. So the first thing I wanted to talk about is kind of the structure. When you start, maybe it's different. I don't know if you did anything beforehand or in your medical school, you were like participating in the rounds. It can be different. It could be like similar because there's very much similarities between hospitals. But in general, when you start your rotations here, the most important rotations you're gonna kind of learn the most in, to be honest, is gonna be the MICU or the ICU rotation, and then the cardiology rotation, which some hospitals have, some hospitals don't, depends on the place you go to. And finally, the internal medicine, general floors rotation. This is the rotation where you're just taking care of general medicine. The other thing you need to know is there's something here called hospitalist. It might be, I don't think it's a thing, at least back home. A hospitalist is just a general medicine doctor. So he's done internal medicine or even sometimes nephrology or something more in fellowship, but they're taking care of the medicine patients on the medical floor, as opposed to people on surgical floors. Okay, so medical floors will have patients ranging from anything from a stroke to like a pneumonia to a UTI to all these things, GI bleeds. Very rarely you will find hospitals that have different sections, which means they have like an inpatient nephrology, inpatient GI, inpatient neurology, inpatient liver. These are very specialized hospitals. Most hospitals will have a general floor medicine, which is what I'm going to describe to you right now. Your responsibilities as an intern. This inpatient rotation here, what I have is the inpatient rotation structure. What I mean here is the inpatient medical floors rotation that you're going to be on. Okay. And as an intern, when you start, they're going to call you an intern. Even though you're in residency, you're technically a resident, a PGY1 resident, but everybody's going to call you as an intern because you're like the first year. Okay. Usually the structure goes something like this. You have the attending on top, which is the attending makes most of these decisions for patient care. And the attending is essentially directly supervising a team. This whole thing is the team. And the team consists usually of a resident and an intern plus medical students, or a resident plus multiple interns and multiple medical students. The resident is usually responsible for all of you guys, for the interns and the medical students, but also the intern is responsible to take care of the students as well as to supervise them. And each one of you, each person on the team will be assigned patients to take care of, including the medical students. They will have their own patients to see and take care of. However, these patients that the medical student is taking care of usually is also assigned for as an intern. You'll be helping out, or you'll be kind of indirectly supervising the medical student. Meanwhile, the resident is the direct supervisor of all of you guys. Okay, the resident usually is not directly responsible to take care of any patients. It's usually you as the intern, you're taking care of the patient. Okay, so that's really important to know. Okay, and there's always a question: is there a maximum number of patients you can take care of? And the answer is yes. The max patients for an intern on the medical floor, is 10 patients per intern. So you'll be responsible at most to take care of 10 patients on the floor. In the ICU, it's 4 patients or 5, 4 plus 1, I think. It could be up to 5, okay? And most of the time, you're not going to be capped at 10 patients, but you could be. And this limit is set from the ACGME. So if your program, if you go to a program where you're suddenly dealing with 12 patients as an intern, that's a violation of ACGME rules. And, you can technically report it, or you can, like, eventually they will get in trouble. So they have to fix it. Okay. Just to give you a little outline about what your responsibility is as an intern when you show up in the morning. What is your responsibility? How do you get sign out? How do you give sign out? How do you get sign out? These are important things on the inpatient rotations. right? Because as you're gonna see, there is usually a day team, and the day team usually starts, officially starts at 8, but usually, at 7 a.m. until like 5 p.m. And then there's a night team, and the night team takes over from, 5 p.m. till 7 a.m. Okay. And you are gonna, sign out to each other what's happening with your patients. Okay. Now, every program will do it differently about how to sign out, but you have to know the basics. You have to know the typical form of sign out. A few years ago, somebody conducted, not a few years ago, I think it's been a while now, but somebody did this research study where they created a quality improvement about how to give sign outs, how to give verbal and written sign out from a team to a team. And they came up with a system called the iPass sign out. Okay, so this system, everybody should know it, everybody should be familiar with, and it essentially standardizes all the sign outs you give your teams. Okay, you might get lectures about this in the pre-intern, like in your initiation course, onboarding, but you just have to know kind of about it. It just means you have to mention the illness severity of the patient that you're taking care of, and then give a patient summary, give an action list about what to do, what's happening to the patient. For example, patient is pending an MRI, patient is pending a CAT scan, pending a TTE. And then you want to do S, which is situation awareness and contingency plans, which means I give sign out to you for a patient who's having a GI bleed. Okay, and I tell you this patient is a watcher, an I is a watcher, which means there's a chance this patient will become severely ill, but for now he's stable. And then I give you the summary, give you what we're doing, plan for like an endoscopy tomorrow. But then the situational awareness is going to be, if the patient develops something, you can do this. Okay, so the more you give situation awareness, the better your sign out is. As you can imagine, as a receiving person, you don't know a lot about the patient, but if you receive some sign out, oh, if the patient becomes hypotensive, suspect hypovolemic shock due to GI bleeds, do this and this and that. Okay, so this would be kind of important. And then finally, whoever is receiving the sign out should kind of reiterate, yes, this is what's happening, I'm going to do this if this, just to kind of give you a verbal feedback that they received it. Okay, and remember, this sign out is going to be not just verbal, it's going to be also written. Okay, every hospital has a different kind of written sign outs. It can either be integrated within the EMR, the electronic medical records that you have, or it can be a different system, like they have a different kind of systems that they use, but they all kind of have the same idea, right? You have a summary of the patient, action list, and kind of situational overnight. Okay, and it could be nothing to do overnight. Sometimes it's abbreviated as NTD, nothing to do. Usually that's the best. Okay, so that's kind of the way you want to give sign out. So you're gonna, usually what happens is you're gonna show up at like, I don't know, 6 a.m., right? 6 a.m. or something, and then you're gonna receive sign out on your old patients, right? So these old patients, let's say you're taking care of like 3 old patients, right? Like let's say 3 old patients. So you're going to receive sign out on these 3 old patients that you had. You're going to get, okay, nothing happened overnight, everything was okay, or something happened, or something like that. Okay. Plus, you're going to get new patients assigned to you. Okay. So these new patients are the patients who were admitted overnight that the overnight team took care of. And then now it's your responsibility. Now they're transitioning the care to you. So they're going to give you a full sign out about what happened to the patient and what's the problem with them. Okay. So let's say you receive 2 new patients. Okay. So now you have a total of like 5 patients to take care of. Okay. So what usually happens is you're gonna first round on these patients, or pre-round, really, it's pre-round, which means you alone, you're gonna go see those patients. And the trick here, what I would suggest you do is see the new ones first, then see the old ones, okay? And the reason is because if you do that, if you do it this way, you will get more information about the new patients. The old patients, you already kind of know a little bit about them. So it's easier for you to kind of get a pertinent history quickly, okay? And then what you really want to do is do a pertinent physical exam, quickly on these patients. New patients get the history, and really what I like to do, and you're gonna learn that kind of either the hard way, is take everything that the person gives you overnight with a grain of salt and verify it yourself. So if the resident tells you this is what happened to the patient, or this is some history, you really want to try to reiterate, get more history from the patient, either things that were missed or things that you want to confirm, okay? Especially if these things are very, very important in the history, okay? And then, after you're going to see your patient, do your physical exam, then as part of your pre-rounding, you're going to go to your electronic medical records. And then this is the way you sit down, and then you're going to start kind of going over what's happening to the patient. I mean, everybody does it differently, but the way I do it is I look first at the notes. Usually you're going to look at the H&P note that was written by your fellow resident. And then you're going to look at any consultant's notes. GI saw the patient overnight, or neurology saw the patient overnight. You want to see what they said, what they suggested, what they recommended. And then you're going to review the labs, especially the recent ones from today. And then you're going to review the imaging, whatever happened, like if they did a CT, if they did an X-ray. And what I recommend, again, maybe when you start, it's a little bit difficult, but I really recommend that you actually see the actual image. Okay, so like, let's say there's an X-ray, you're going to read the interpretation of the radiologist, there's no cardiopulmonary disease, but it's good practice for you to click on it and see the actual image, just to have it in your mind, okay? It's tough when you start, but you'll learn to get to it, okay? And then, you want to review the micro, whatever they have micro in terms of like blood cultures, urine cultures, sputum cultures, stuff like that. And then review the medications. The medications, what I mean here is the active inpatient medications. And some people like to write all these things down so that when you're presenting to your attending, you have all the information written down, okay? Like for example, in terms of labs, some people like to do the skeleton. I don't know if you know these things, but some people like to do this. Like, you have the hemoglobin, and then you got the WBC, you have the platelets, and then, potassium, sodium, BUN, creatinine, blah, 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 like all these things, okay? Whatever, people do it differently, do it the way you want. There's no right or wrong way of presenting your labs, as long as you don't miss anything, okay? And then, finally, you can also review their meds, the outpatient meds, okay? Because you don't know if you missed some meds that weren't started. Like for example, somebody needs their tamsulosin for BPH, wasn't started, you don't know why it wasn't started, then you can restart it, okay? And then finally, any other issues, and then finally what you want to kind of formulate in your head is an assessment and plan, okay? This in your mind, because this is really the important thing. Obviously, you can kind of, reference the assessment and plan that was already written in the note before you, because a lot of times it's not going to be different. But sometimes you might disagree with the person who admitted the patient overnight, and then you can say, okay, this is what I think, okay? And then finally, what I recommend all of you to do is when you start, because you won't have enough time, is to draft your notes. Because a lot of times what happens is that you're going to be rounding with your attendings until like 2 p.m. or something, and then you're going to, rush back to the resident room, now start to write the notes. It's going to take you a long time. So sometimes it's really important to just, draft the notes and have them ready, so that when you're back, you can change a little bit of assessment and plan, just sign the note and get it over with, okay? Again, you learn to be efficient slowly. At first, it might be overwhelming to look at all these things and try to keep up with everything. If you have 10 patients, imagine doing this for every patient. If it takes just 10 minutes, that's like an hour and a half just to look at the notes, okay? Just to review your patients. So it does take it's time consuming. You'll get better slowly. But I think if you have a system in your mind about how to do things, you will get better. You'll get more efficient, okay? Any questions about this? Okay, cool. So, I mean, it's pretty simple, but again, it can be time consuming when you start. So like, for example, me personally, when I started my residency, I used to show up at 5:30, not at 6, and like just do all these things and like get it over with. And then by the time it's 8 or 8:30, I'm already done. Like I saw everything, I'm ready to round. And a lot of attendings like to round early, like at 9 a.m. Depends on who you're rounding with. In the ICU, it's kind of a different beast. In the ICU, you might start rounds at 7:30. So you might want to be done by 7:30.